Why are so many women misinformed when it comes to heart disease? Here are some surprising statistics. According to the CDC, about 1 in 16 women aged 20 and older have coronary heart disease, and about 1 in every 5 female deaths are heart-related.
It is the leading killer of women in the United States and actually globally.
But even today, and despite an increase in awareness, only about half of women recognize that heart disease is their number one killer. Are those numbers across the board? Do they change with ethnic backgrounds or socioeconomic? How do those numbers vary?
Yeah, definitely. I mean, the risk for heart disease increases, particularly for people of more diverse backgrounds. So meaning if you are Black, your risk of heart disease is even greater. South Asians, your risk of heart disease is even greater. And of course, social determinants of health play a role, meaning that the other things that contribute to lack of access to health care, lack of preventive care, unable to buy medications that are prescribed, unable to actually take the time to go see a doctor until it's too late. Those things definitely contribute to the greater risk of heart disease. And right now, that's a big conversation because, of course, we don't have a universal healthcare system. So people who really need the preventive care are often the people that don't get the preventative care. And people who need access to doctors, maybe they have subpar health insurance, or they work at times where it makes it impossible for them to take time off for their care. They're not in the luxury as many of us are, where we're like, oh, I'll just block off an hour and go see my doctor.
Right.
You know, they can't always do that. And so it makes it very difficult for them. You know, anytime I talk about getting your heart checked out, it also makes the assumption you have the time for it, that you're able to leave work for it. Remembering doctors' hours are other people's working hours.
February is American Heart Month, a time to raise awareness of cardiovascular health. If we can make Heart Month half as popular as Breast Cancer Awareness Month, I think we might save some lives. Every October, we turn everything pink, and I just don't think it gets as much attention. Why do you think that is?
Yeah, I don't know. You know, we often say that breast cancer has the best PR agent and heart disease doesn't. And similarly, you know, they get October, which is a 31-day month, and we get the shortest month of the year to celebrate the heart and to talk about heart disease awareness. Really, I mean, I'm saying this seriously because I think that for women, they really do understand the risk for breast cancer. But when you actually look at the statistics, over 420,000 women die each year from cardiovascular disease, compared with 41,000 women who die from breast cancer. It is a tenfold greater risk of dying from heart disease than it is for breast cancer. And we don't understand why we haven't done as good of a job at communicating this information to women. Women go for their mammograms. They're told the importance. The Pink Ribbon campaign was incredibly successful and one of the things that we can all learn from. But going red in Heart Month and the Red Dress campaign has not been nearly as effective at educating women and making them understand what do you need to do to protect your heart.
That is Dr. Martha Gulati, the president of the American Society for Preventive Cardiology and a cardiologist at Cedars-Sinai Heart Institute. Dr. Gulati says that heart disease is often preventable and treatable. In this episode, you'll understand how to prevent heart disease and know the warning signs so you can get the treatment you need before it's too late. This is the Grown-Ass Woman's Guide. I'm your host, Jackie McDougall. Welcome. Dr. Martha Gulati is a professor of cardiology and director of prevention at Cedars-Sinai in Los Angeles. Among many impressive credits, which you can read in the show description, she's been awarded the National Red Dress Award for her efforts in raising awareness of heart disease in women and advancing research in this field. And she was also chosen as the most influential woman in Arizona and received the 2019 American College of Cardiology's Bernadine Healy Award for her leadership and accomplishment in the field of cardiovascular disease in women. For Dr. Gulati, prevention is everything. And what does preventative care look like?
Yeah, so I wish we had like a heart mammogram because, women really do understand that they need to go for their mammogram every year and they're good about doing it. And, we've really communicated that one step that's necessary. When you're actually talking about getting your heart checked, I mean, the first thing is what women should be asked is, do they know if they are at risk for heart disease? If you don't know the answer to that question, then it is time to go talk with someone, whether that's your primary care physician, your family physician, even your OB, because a lot of women identify their primary care physician as an obstetrician, gynecologist. Mm-hmm. And even though I think most OB-GYNs will tell you that they're not necessarily doing everything, they are quite good at recognizing their role in women's health. And they are often taking on that role. But of course, at the time that you're at the physician's office, it depends what issue they're addressing and whether you actually leave equipped with that information, meaning, do you understand if you're at risk for heart disease?
Okay.
The basic measurements, I think that it should be done for every woman at literally every visit. Blood pressure should be checked and communicated to women. Not just as women, we shouldn't just accept knowing it's normal. We should know our numbers. We should ask for those numbers. We should ask, what is my blood pressure? Because in reality, we've changed what is normal. Meaning now normal blood pressure is the top number, called the systolic blood pressure, is to be under 120. And the bottom number, which is also known as the diastolic blood pressure, that's to be under 80. And those changed in the last few years. So maybe you were told it was normal, but now if you look at it, it's not that normal anymore based on our new guidelines. They should know what their cholesterol is and really their whole cholesterol panel. But if they only remember one number, the number to remember is your LDL cholesterol. I remember LDL as lower is better, L for LDL, L for lower. That one, you really want to know that your LDL cholesterol is where it needs to be. And for some people, it's at different places. But a ballpark is to know that ideal LDL is at least less than 100. If you have heart disease or you're high risk, people may want it to be even lower.
Okay.
People should know if they have been screened for diabetes and what their fasting blood sugar is. Maybe they'll know what their hemoglobin A1C is. Some people will get that done just to assess for diabetes. But if you don't know, or you don't know if you've even been screened for diabetes, then you should ask for that to be done. You should also know your waist circumference. Under 35 inches is what we say generally for women, but actually based on race, there's different measurements, meaning like South Asian women tend to be smaller. And so therefore they don't get the luxury of having a waist of 35 inches. It actually should be lower for them. And then they should know what their body mass index is. And I think most women hate talking about weight, so we can talk in body mass index. And what a body mass index represents is, are you tall enough for your weight? That's the way that I like to think about it. You want your BMI or body mass index to be under 25 kilograms per meter square. And unfortunately, usually as an adult can't grow in height. So that means that maybe your weight is a little high if you are above 25. And again, I know nobody likes talking about their weight. So there's other ways that we can talk about it, but we certainly know that we need to be discussing whether it's the waist circumference, whether it's BMI, in a way that our patients feel comfortable and that women also feel comfortable talking about their weight. Those are some of the important parts of the assessment.
Can we talk about BMI for a second? Because it's very controversial in that it doesn't really allow for different body types or ethnicities or, muscle. Can you speak to that for a second?
Yeah, definitely. When BMIs, especially for very tall people, sometimes will look bad and then they're not not representing sort of the body habitus of the person. I don't think BMIs are the perfect assessment. But I do think it's a starting point, at least to know what it is and then discuss, does it apply to you? I think with the assistance of waist circumference, though, it can tell us if you carry your weight centrally. That's why I like waist circumference. I carry around a measuring tape in my lab coat. And I think it is really a good way to talk about where our weight is distributed. For example, if you've ever heard of the body shapes, if you're a pear shape is better than an apple shape, because apple shape means we have central obesity. And that central obesity or central weight gain, if you will, is associated with a higher risk of insulin resistance, a higher risk of developing diabetes, essentially. And that's the metabolic syndrome. I jokingly say that if your abdomen enters the room before the rest of you, then you have central obesity or central weight gain, and you might have metabolic syndrome. Okay. And that's really what we're trying to identify. Diabetes is a big issue in our society. If we did a better job of identifying people at risk for diabetes earlier, there's a lot of treatments we can do, and particularly working on diet and weight loss and exercise. Doesn't really mean medication intervention, but I think a lot of people, we just avoid the whole discussion about weight. And I get it. I know that I have actually some women patients who tell me they don't want to see their weight. We're not going to talk about their weight. So we talk about it in different ways. When we measure their weight, they look the other way. I record it, and we've made a deal that we're not going to talk in those numbers. But we do need to at least have a way to communicate what the risk to the heart is. Ultimately, the most important organ in the body is the heart. Without the heart, we can't be here. But of course, I'm biased because I'm a cardiologist. but really,
but I think you're probably spot on.
Yeah. So I mean, it's essential for every organ's function, and so we really do need to be having these discussions with our patients in whatever way works for the women that are with us.
I mean, we could have a whole conversation about the way women are shamed about, in regards to weight. And so, but that has nothing to do with your looking at weight as just information about the risk.
Yeah. And I will also admittedly tell patients, I don't even worry about the number. I just want to be able to identify if they're at risk. And then we can move on. If we never talk about weight again, that's fine. But I think that when we do risk assessment, and then the tool that we use in the United States is something called your ASCVD risk score, or it also stands for atherosclerotic cardiovascular risk. And it's a risk calculator that anyone can look up, and we punch in your numbers. So the only thing different between men and women is we put in women versus men, like whatever their reported gender is. And then we put in their cholesterol, their blood pressure, whether they smoke or not, whether they're diabetic or not, whether they're on blood pressure treatment, and whether they're on cholesterol treatment. And then we assess the risk. But that's just the beginning. That's part of risk assessment. But for women, they really need to know that there's other things that can put them at a higher risk that are unique to women.
Okay.
One example is only biological women can get pregnant. And during pregnancy, I always call pregnancy nature's free stress test, because it actually helps us identify women at the time of pregnancy as who are the women that are going to develop heart disease in the near-term future, meaning within the next 10 years, those young heart attacks that we see and that we want to avoid. Those are women who have had pregnancy-induced hypertension, whether that's preeclampsia or eclampsia or just elevated blood pressure. Those women are at a higher risk of developing heart disease. Similarly, women who develop gestational diabetes, they're at a higher risk. I know most of the gestational diabetes immediately disappears after delivering the baby, but you're not just at a risk of developing diabetes in the future, but you're at a greater risk of developing heart disease in the next 10 years. Other things that can occur during pregnancy: having a preterm delivery, having a small for gestational age baby are also unique risk factors that can only happen to biological women. And we need to be asking about your pregnancy history to identify those women early and be very proactive in our preventive heart care, because those are the young women I see and hate seeing in the hospital that have had a heart attack because nobody talked to them about their risk.
Wow. Yeah, I had gestational diabetes and no one ever mentioned that, which is surprising. So what about women who haven't had children? How are you kind of understanding their risk when they're younger?
Well, still there's sex specific risk factors. And in fact, frequent miscarriages is also something we ask about, because that puts women at a higher risk potentially of heart disease, depending on the underlying cause, but also other things that may make women not get pregnant. And I'm not saying that every woman wants to get pregnant, but polycystic ovarian syndrome puts women at a greater risk of heart disease. People who have had early menopause, they are at a higher risk of heart disease. Some women who suffer from anorexia or bulimia, who have functional amenorrhea, meaning their periods just stop, that puts them at a higher risk of heart disease. And there's other things that just affect women that don't have anything to do with us getting pregnant, I guess. Early menarche can put women at a greater risk of heart disease. Early menopause, as I already said, can put them at a higher risk of heart disease. But diseases like lupus and rheumatoid arthritis, which are also seen in men, but are much more common in women, those are associated with more inflammation and therefore more heart disease. Additionally, if you've had breast cancer, you are less likely these days to die from breast cancer. This is because of all the advances in our treatments, in our preventive screening. And so women do very well these days in terms of when they have breast cancer, the good treatment we have out there. But both the disease and the treatments increase the risk for heart disease. And so we need women to understand, who have had breast cancer, that they're at a higher risk of developing heart disease and should be very proactive. Of course, in their breast cancer follow-up, they should see their oncologist and do everything that they tell them, but they should also consider seeing a preventive cardiologist so that they can also protect their heart. They didn't go through all that treatment then just to suddenly have a heart attack or to develop heart failure as a consequence of their treatment. So we really need women to know that there are things unique to us being a woman that put us at a higher risk.
Right. So what are some of the signs that things aren't right with the heart?
Yeah, I mean, there can be a lot of different signs because there's a lot of different forms of cardiovascular disease. But the one common things being common, let's talk about having a heart attack or having reduced blood flow to the heart, which is known as ischemia. When people experience angina, that's what the symptom, usually the way we describe it in medicine, is. It's somebody experiencing symptoms because there's reduced blood flow to the heart.
Okay.
And those symptoms can be chest pain or chest pressure or chest discomfort, but it also can be other symptoms even without any chest pain present. It might be neck pain or jaw pain or left arm pain or left shoulder pain. It can be shortness of breath, particularly shortness of breath when you did an activity yesterday that was no problem. And then suddenly, you're walking up the same flight of stairs and you're like, I can't do this. There might be something wrong with your heart. Similarly, back pain. Back pain can be a sudden onset symptom. And then for women, often can report dramatic fatigue. I don't mean just the fatigue we have day in and day out, because otherwise we'd all be lining up in the emergency room. We're all tired. But the type of some sort of dramatic fatigue, like you just can't get out of bed. Or you're like, I can't do anything and I don't know why. That's the one to worry about. I tell people that any discomfort in the thorax, chest area that's above your belly button, you should think about, especially when it's new in onset. You think about it potentially being your heart. And that's what I also tell physicians. I wrote the chest pain guidelines that came out. I was the chair of the chest pain guidelines that came out in 2021. And we made it clear that, there's not one perfect word that's going to be said that we, as in medicine, are going to be able to perfectly identify. But we do not want to miss women, because we've been missing women. We've been underdiagnosing women. And we continue to show that we discount women's symptoms too often. That results in delays in care. And when you're having a heart attack, time is heart muscle. If I could give you an example, though, of something that a woman experienced, just to share with you how easily we discount symptoms. And I'm really blaming the medical community, not patients. So, but I remember this patient from my training days. The patient actually, her husband had ischemia and had presented to the doctor with, chest discomfort and mostly though his symptom was left shoulder pain. And they took him to the cath lab. They opened up his artery and, everything was good. And they were in the follow-up visit with the cardiologist. And the woman had actually asked his cardiologist, she goes, it's funny, I have left shoulder pain too. Do you think I should be worried about it? And he turned to her and said, well, which side do you carry your purse on? And she said her left. And he said, okay, carry it on your right. I met her that evening in the emergency room when she was having a heart attack. And so, we do not recognize easily. Admittedly, she was there with her husband's appointment, and I'm sure the doctor did not examine her because it was his appointment.
Right.
But it is interesting how she had the same symptom as her husband, but it was so easily discounted.
Yeah.
And so, I just want women to know, I wish they didn't have to advocate for themselves, but advocate for yourself. If you've heard this podcast and you're in the emergency room and they don't assess your heart when you're having such symptoms, just ask, could this be that I'm having a heart attack? Because that will at least get the physician motivated to think about it. And hopefully in the meantime, we start or continue our education to make it clear that women and men are at risk for heart disease. It has been a big issue, really getting this information out as much to the public as to the medical community.
Right. And do you think there's a combination of, yes, women have been disregarded, our symptoms? I have a grown-ass woman's guide community, and I'm sure if I asked them in there, many people would tell me about a time that they were disregarded. And also, we tend to disregard our own feelings sometimes, like, oh, maybe it's my purse, or maybe it's this, or I'm sure it's fine. I've got this and this and this to do. I don't have time to have a heart attack.
Absolutely. For women, I will say that this is one of the things we always hear is by the time they get to the emergency room, it's usually bad because they're like, well, I don't want to bother the doctors, or, I don't know, is this really anything? Or I've got 1,000 things to do and this is just disrupting my day.
Yeah.
And so if it's still here in a few hours, maybe I'll deal with it. And there's a great video made by the American Heart Association. And I'm forgetting the woman's name who stars in it, but it's a video and it's called Just a Little Heart Attack. Oh, Elizabeth Banks. That's her name.
Oh, okay.
Elizabeth Banks did a wonderful PSA for the American Heart Association, really depicting a busy woman trying to get her children off to school, getting her husband off to work. And meanwhile, she's popping Tums because she thinks what the discomfort she's having in her chest is just indigestion. It's not going away. And just before her son leaves to school, he takes her phone, looks up her symptoms and says, it looks like you could be having a heart attack. And that's what prompted her to call 911. Meanwhile, her house looks like a mess. And when she actually gets the 911 operator on and they say they're going to send somebody, you can tell she's horrified because her house looks like it's a mess. And, she even says, I might be having a little heart attack, but she's focused on, what else she needs to do.
Right.
And it's a beautiful example of really women kind of not prioritizing their health. I always say that if you would call 911 for your husband, then please call 911 for yourself if you're experiencing those symptoms.
Right.
Time is heart muscle. The quicker we see you, the quicker we can assess if it is a heart attack. Mm-hmm. If it isn't a heart attack, nobody's going to get mad at you. Nobody's worried that you're wasting their time. That's what we're there for. And in fact, the biggest portion of chest discomfort or chest pain that enters our emergency room, the majority of it is not a heart attack. But we don't want to miss anyone having a heart attack. We do not need more stories of women dying at home because they didn't call 911. We do not need women to worry that they're wasting our time. That's what the emergency room is for, is to determine, is this something life-threatening or not? And we'll tell you. We won't ever tell you that you're wasting our time, in fact, but we'll tell you if it's not your heart. And we can all, talk about that later, but we do not need to worry about that. Nobody's going to judge you based on that, but you want to be there. You want to be there for the people who depend on you, whether it's your children, whether it's your parents, whether it's your husband, whether it's all of the above. Then please don't discount something new that is occurring and affecting your ability to breathe, to work, to walk, to do things that you could do the day before. Please have them assessed.
Yeah. And so when you go into the ER and they do probably an echocardiogram?
Well, if you come into the emergency room, the most important thing that they should do, if this is new chest discomfort or pain above the belly button, they should get an EKG. That should be one of the first things that occur. An EKG is an electric tracing, basically the tracing of your electrical activity. Our hearts give out these electrical impulses that they capture. And what that strip of paper that we're all looking at and why we're so interested in it is it can tell us if you're having the most dangerous type of a heart attack. Something called an ST elevation myocardial infarction, or a STEMI is what we in medicine call it. But the type of heart attack that is so important to get you up to the cath lab and get that artery open. That's the one that we talk about. Time is heart muscle. Time is every second counts, because we need to open up your artery and get the blood flowing again. And that is the one that we can diagnose by the EKG.
Okay. And that's easy. That's just the stickers.
That's just stickers on your skin, and you just get to lie there and breathe. And they might do some blood work, and they should do some blood work to make sure that the other types of heart attacks may not have the EKG changes, but may show in your blood work that something acute is going on. Then from there, they'll decide what the next steps are. It might involve other types of cardiac imaging, and there's a lot of different imaging we can do. We can do tests that look at the anatomy, but are non-invasive, called a coronary CTA. It's a CT scan of the heart. Sometimes we'll do something called an echocardiogram, which is essentially an ultrasound of the heart. If you've ever had an ultrasound of your baby, it's using the same equipment, but looking at your heart. Sometimes we'll do something called a nuclear stress test, that is a stress test, but again, taking images of your heart. Sometimes we'll use a cardiac MRI. Sometimes we'll just put you on a treadmill to see if we can reproduce your symptoms. But all of that will be decided by the specialists who consult on you, or the emergency room physicians who see you, and decide, does that need to be done? Sometimes we can tell people right away that you're very low risk, because we'll do a risk score on them, and we can decide together with that patient if maybe we should do some testing later. Maybe it doesn't need to be done in the emergency room. But again, it's the end. If we don't get to see you, then we don't get to make those decisions. And I will tell you, so many women do have heart attacks at home.
Yeah. And so let's talk, before we get to the symptoms and all of that. When we go for a physical, should we be getting that blood work and the EKG done at that physical?
So not the blood work that's screening for when you're having acute chest pain or acute chest discomfort. And again, even with the EKG, we should have an indication to do an EKG. What you should have done at your primary care is you should know your blood pressure. You should have had your cholesterol screened at least every 5 years. And if there's something abnormal, they might start checking your cholesterol yearly. They should be screening you for diabetes, all the things that we talked about, knowing your weight, assessing how much exercise you do, assessing those pregnancy and female specific risk factors, and then the female predominant risk factors. You should leave knowing your 10-year risk for heart disease and your lifetime risk for heart disease. It's a number, but they should be able to explain to you, are you high risk or not high risk? Are you low risk? Maybe you might have a low short-term risk, meaning in the next 10 years, your risk is low, but your lifetime risk tells us that you're very high risk. That's a different, that's very different, because when you're young, almost every young woman will be told that their short-term risk is small. But if your lifetime risk is high, then you should be working with your family physician, internist, or cardiologist to trying to reduce your future risk. And that's what preventive cardiology is really about, is really what can we do to save your heart?
Right. So let's talk about that real quick. So preventatives, I think that we're all waiting until it's too late, right? So what are some of what are the most important things we should be doing to protect our heart?
First of all, we should be eating better. There's less than 1% of the US population actually adheres to the guideline directed diet that we advocate to prevent heart disease, which is the Mediterranean diet.
Okay.
And, most people don't say that that's what their diet is. So I think the most important thing we should be doing as a society is improving our diet. More plant-based, more plants, eat more plants. It doesn't matter which ones, you just eat what you like, but more of them. I always say if you're getting a rainbow diet, you're probably doing a good job. It doesn't mean that if you like meat that you can't eat meat, but just reducing it or limiting it, or, maybe not eating the highest fat meals, or which are usually composed of meats that are higher in saturated fats. We should be reducing saturated fats and trying to use oils, for example, that are plant-based, things like olive oil. That is one of the best ones, but really any plant-based oil. Although coconut oil, I will just say that don't think that coconut oil is good for you. It's very high in saturated fats. And I get a lot of people who ask me about, but I'm using coconut oil as we watch their cholesterol rise. So I would just want to stamp that out right now, especially if you have an underlying cholesterol issue. So you should be getting you should be discussing what is my cholesterol as well. And that might have some influence on what diet people recommend for you. But in general, we tell people to adhere to the Mediterranean diet because it is the one diet that we have the most evidence that the people that follow it have a much lower risk of developing heart disease. So that's the first thing. We should also be asking people, they should be asked about how much they exercise and how active they are. I don't think exercise is everything, just so you know. Even if you follow my Instagram page, you'll say she exercises every day, but I do. But I also care if you're just active. Okay. So, meaning in your daily life, I have many patients who don't make a effort to exercise, but they're literally on their feet all day, moving, gardening, doing things around their house, walking to work, walking to the bus stop, which is a couple miles from their house. Those things all count. So if you achieve 10,000 steps a day, I will never harp on you that you have to do extra activity. If you do, great. But if you, the more the better. But 10,000 steps a day or 30 minutes of active activity every day. And to be honest, I will always tell people, if you're going from nothing to something, then I'll take the something. Right. And we can gradually build it up. But activity does not have to always be exercise, because I know there's always people out there who say, I literally hate every exercise. Then don't exercise. Find things that you do that keep you on your feet all day. The biggest problem is what most of us do and work every day is sitting in these chairs and sitting for many hours at a time. Many jobs that used to be much more on our feet have become highly stationary jobs. Right. So the more we can do, the better. Just by getting out of our seats, instead of sending an email to the office next door to me, if I can, I just walk over there and say, hey, I was going to send you this email, but maybe this is my excuse to get out of my seat. So again, I think that's where activity trackers are really great, because at least they can give you some perspective of how sedentary you are versus how active you are. Right. And that can help you monitor. I know people who will get home and they'll look at their watches that monitor their activity, and they'll be like, my goal is 10,000 steps. So they just keep walking until they get the 10,000 steps before they come in, because they know they won't get the activity after.
Right. Well, I'm guilty of, I'll get up, I'll do my exercise, 30 minutes, whether it's on the Peloton bike or one of their strength training workouts. And then I'm here working from home, And so basically the walking I do is from the office to the kitchen, maybe to the car to pick up the kids from school. But I'll look and I'll be like, I got 2,500 steps today. A great workout, but only 2,500 steps. Which one should I be focused on? The 10,000 steps or the workout or both or?
Probably a bit of both. There is some evidence out there that people who even exercise for their 30 minutes a day, even when they do it for a good moderate intensity workout, when they do spend the rest of the day sitting, and especially if they have a prolonged sedentary hours, they are the ones that seem to also not get as much protection out of the regular exercise.
Okay.
So I still think that, we need to be cognizant on the, if anybody has any of these smartphones, will always tell you how many hours you didn't move much or didn't get up out of your chair. I think we need to move more. Our society has become highly sedentary. And so I think these things are really important. I don't tell you to do anything that I don't do myself. I'll just be clear on this. I exercise every morning. I run my 2 dogs. I also use my Lululemon mirror for at least 30 minutes a day for strength training, because I think that's an important part that women need to also do, not just cardio.
Oh, I'm glad you mentioned that, because I'm picturing like the Jane Fonda workouts from the 80s, like always cardio, that's like heart cardio, right? So strength training is just equally as important.
Just as important, especially for our bones, but also for our heart. Both of them are needed. And I will say the other thing I do is because I was realizing, especially during COVID, how sedentary my life became after my run was over, that I started walking to work. And so I walk 3 miles to work and 3 miles home, because it's almost like I have to pay my dues for the amount of sitting I do in my job, which I know sounds surprising, but really even my job has become a lot of sitting. So I am very much about moving. And I tell all my patients, I'm like, I will never ask you to do something I don't do myself, or the things that I have struggled with myself. But these things are very important.
So you walk 3 miles both each way, and you get your workout in the morning.
Yes.
And you run your dogs.
Yes. Yes.
We can't keep up with you, Dr. Gulati. So earlier this morning, I posted in our community asking if any of the women had questions, and I got a few. Are you cool with answering some of those?
Sure. Absolutely.
Awesome. And you may have actually touched upon that. So Michelle asks, what is the best diet after you are diagnosed with heart problems? And would you say the Mediterranean diet? Before
or after you have heart disease, the Mediterranean diet wins. If you have hypertension, I will say that you've probably heard, some of you might have heard of the DASH diet. And the DASH diet is really the Mediterranean diet, but with lower sodium. So if you have trouble with your blood pressure, I think keeping a low sodium diet is a good idea. I certainly advocate for low sodium even before people get hypertension, but that will come from being plant-based, because when you eat more plants contain a lot more potassium. Potassium counters what the effect of sodium is. So meaning food that is rich in potassium will lower your blood pressure, and food that is rich in sodium will raise your blood pressure. So again, if you're having any issues with elevated blood pressure, think about both parts.
Okay. And so if you don't have any issues, what is the healthy amount of sodium? What should we be looking at today?
I mean, our U.S. diet is very high in sodium naturally, and most are exceeding the recommendations. You should try to keep it under 2 grams of sodium a day total. I will tell you, most people are getting far more than that. So it's much harder to get it, to make it be a low sodium diet. That means removing the salt shaker from your table and from your cooking. It means watching and reading the labels of the food that you eat. And I would say that it means perhaps making more of your food, meaning if you like prepared sauces, for example, a lot of them are really rich in sodium. But if you make them yourself, you probably won't add in that sodium. A lot of it is for shelf stabilization. And at restaurants, it's often so that you'll drink more. So but they add more salt. Bread, for example, is something that people really underestimate, but bread is one of the biggest carriers of salt. So again, when you're buying bread for your home, look and read the salt content, or make your own if you're so talented. Because again, and when we even like things like pizza, you buy pizza, it's higher in sodium. And so you just have to be careful. A lot of hidden places for salt. And those, the bread is the one that I think people tend to underappreciate.
Yeah. I wouldn't have even thought about that, that bread is the place to get all that salt.
Yeah.
So Myrna asks, is butter in moderation better or worse or the same as butter substitutes?
Oh, well, it's a hard one. That's a hard one because, in the past, of course, people touted things like margarine as good for us, and because it, for a lot of different reasons. But again, those things, anything made with trans fats is terrible for you. So don't use margarines like that. There is things out there that are made of plant-based oils that are perhaps better than butter. But again, if you're going to use them in excess, they're never going to be good for you. So just be careful. I think butter in moderation, meaning if you're, it depends what everybody's definition of moderation might be a little bit different. I think it's okay to once in a while use butter. If that's something that makes you happy, then use butter. But if it's an everyday thing, like that you're every day having a piece of bread and every day it's slathered with butter, or every day you put butter on, I don't know what else people use butter on, but potatoes or something like that, and you use it in large quantities, then it becomes a problem, particularly if you have elevated cholesterol already, because certainly butter is saturated fat. But I will also admit that I have occasionally do use butter, and I will use, really on fresh homemade bread that somebody gives me. I think it's like the best thing in the world. So it's that one little treat that I have. Is again, I think a lot of what has happened to our diet is it's been our excesses. Food is so available. And so we, it's like we have butter every day, and we have, all the things that are bad for us literally many days a week. And so we really need to look at what is the moderation really mean for us and how it relates to also our labs. I don't think that you have to completely eliminate it, except if you have heart issues, then talk with your doctor. If you have cholesterol issues, talk with your doctor, because then you do need to be a little more strict.
Right. And what I'm hearing too is that we need to be a little more intentional with our food. If somebody's baking you something delicious and you want to have bread and butter and it's like amazing, great. But if you're opening that Wonder Bread that we had in our childhood and slapping some butter on, you may want to rethink your habits.
Yes, absolutely. And I think that, we need a better relationship with our food, enjoying our food, but smaller quantities, I think is a way for us to even think about the things we like. I read once this article that everybody needs at most 7 bites of the thing that they love. And so then even when I love certain food, I try to always remember that. I'm not always perfect at it, but I try to be like, okay, 7 bites. And then my brain's happy, I'm happy. And then I'm like, okay, I can push it away. So that's for me, especially related to sweets. I like sweets, but I also know it is my mortal enemy. So how can I have it, but also not eat the whole thing?
Right. That's a great tip, 7 bites, because then you get to have it. I'm the opposite. I'm like, I'm never going to have this thing again. I'm going to cut all of this out of my life. So I'm going to eat all of it right now. So it's not in my house. So yeah, there's a little warped thinking. We'll talk about that one later. But I don't think I'm alone in that idea.
No, not at all.
So Tammy talks about menopause and how does menopause affect the heart? And then she talks about having heart palpitations. Is that causing damage? Like heart palpitations that happened after menopause.
Yeah.
And is that causing damage?
Those are great questions. So first of all, when I see women that are at the age that they could be postmenopausal, certainly that's one of the sex-specific things we should be asking women about. And if they've gone through menopause, we know that that is certainly going through menopause is a time where we see a lot of changes in risk factors, particularly cholesterol starts changing, body weight sometimes starts changing at that time. And it's an important time to be very proactive and be talking about how things that we should be aware of and doing that can help protect the heart. And certainly blood pressure can also change at that time, although there's more evidence saying that it may not be just at menopause, but it's just gradually going up as we age. But it is often a time that women reconnect with their doctors. And so it might be that they didn't talk to anybody about anything, and then suddenly they're there and we're able to say, hey, your blood pressure is elevated. You have hypertension, whether their cholesterol is elevated, whether they meet criteria for the metabolic syndrome. But at least, even if all those things are normal, to talk about their future risk and start talking and understanding the risk for heart disease. So the other part of the question, sometimes, they may experience hot flashes, but they also may experience palpitations. And palpitations can happen for a number of reasons. We also see it sometimes when women are pregnant. So these hormonal changing times, with pregnancy and menopause being two of those times, women can experience palpitations. And the most important thing is to have them evaluated and know if they're just benign, something that doesn't mean anything, or if they're more serious, especially around menopause where things to the heart might be changing. And if, for example, somebody's in atrial fibrillation, that's, first of all, puts you at a higher risk for stroke, but also if it's going on a lot, can cause structural changes to the heart. So we don't want it to be ignored. That's for sure. And we don't always want to blame it on hormones either. Sometimes it's just coincidental that you've been going through menopause and suddenly we're also seeing you experience palpitations, but there's something going on. For many women, though, they might be aware of skipped heartbeats is what they feel. Actually, they usually don't feel the skip. They usually feel the pause after, and it feels like their heart stops for a second and then it restarts. And that can be scary, but I'll tell you, most often that's normal. But again, I always tell people, don't be Dr. Google. Don't go online, because it'll scare you too. It can tell you all the scary things, but it also might convince you it's something that's not worrisome, and it is.
Right.
And so, talk with your doctor at the time. Menopause is a great time to reconnect with your doctors and to just know what's going on and to know what your heart risk is, and then be more proactive about the things you can be, and also treat the things that are recognized at that time.
Right. And you make a great point, because if you're at home or in the car and you're listening to this episode and you're like, oh, well, that's normal because she just said that. You are a unique individual listening, and go with your gut too. Like, go see your doctor if you feel like something's wrong.
Yeah. Women are the best. I will tell you, I love taking care of women because they really know when something has changed. And I've learned to never discount what my patient says, because they will be like, this wasn't happening, now it is. And usually their intuition is right. And so again, something we're very in tune, right? Women have always known we have periods. So we learn to know the changes that occur in our body. We recognize, most women know, oh, my period's coming because my breasts are tender, or I feel yucky, or I'm moody, or whatever the thing is, that we are so in tune with our bodies. Why would we not be in tune when we think something's wrong, something's changed? I believe women, and we need to listen. We need to be better at listening to women.
Oh, yes, absolutely. Thank you for saying that. So if someone were to tune into this episode, they have 1 minute of their life to give to this episode, and you could tell them the most important takeaway from all of this, what would that be?
I think it's sort of what we just talked about, is that when something acutely changes, don't discount it. Mm-hmm. I think also the next thing is to prioritize yourself. I know it's hard as a woman to ever put yourself first, but if you want to be there for all your loved ones, then it is important to understand that If you don't put your own health first, you will not be there for your loved ones. And there's just too many stories of women that we have lost, of things that we could potentially have prevented.
Right.
80% of heart disease is preventable, but we don't do a good job at being the early interventionalists that we should be. And I always like people to know this. Heart disease is the number one killer of women, but lack of awareness is a close second. And the more that we can share this information with women to empower them, to help them engage in their care, the better we will be. So even sharing this with other women and making them know that this is such a great risk for women can be the difference between life and death and changing the statistics, which continue to get worse.
Right. Thank you so much, Dr. Gulati. You are brilliant. And I just think that this episode will help so many women speak up with their doctors, show up, pay attention to their bodies, and maybe even prioritize themselves. So that would be pretty amazing.
That would be great. Thank you for having me.
To keep the conversation going, join our Grown-Ass Women's Guide Facebook community and follow grownasswoman.guide on all the social channels. And for a transcript of this episode, visit grownasswoman.guide. Thank you so much for listening. If there ever was an episode to share with a friend, this one is it. It could save a life. Until next time, remember, you are a grown-ass woman. Act accordingly. Spring has sprung, and with the change of seasons, sometimes comes an increase in vitality. If you're feeling in the mood for a little more personal time, may I suggest Coconut. Coconut is all about providing clean and natural ingredients when you're enjoying your most intimate moments, with or without a partner. Naturally safe products developed by people who are obsessed with quality. Get 15% off with promo code GROWNASS at grownasswoman.guide/Coconut. That's 15% off with promo code GROWNASS at grownasswoman.guide/Coconut.